gentlemen, dear Chairman. So I will give you an overview over which tumors need more treatment than just surgery. Let's see how this works. The first statement is something you will have to remember whatever I say after this. Multimodality therapy is the standard of care today for these cancers. And there are several types of adjunct therapy that are evidence-based and supported by guidelines. We all know this perioperative chemotherapy is used for adenocarcinomas of the stomach, junction, and esophagus. They had their breakthrough after the publication of the MAGIC trial, and the regimen has recently been changed after the FLOT trial results were known. So FLOT is now the new standard. We have neoadjuvant chemoradiotherapy used for esophageal and cardioadenocarcinoma, but also for squamous cell carcinoma. And they had their evidence breakthrough. They were used a lot for many years, but after the CROSS trial was published. And we also have adjuvant chemotherapy used mainly for gastric cancer in Asia. And the evidence is based on the Japanese S1 trial and on the classic trial from Korea and Taiwan. And we also have neoadjuvant chemotherapy for esophageal cancer mainly, and the Western data are based on the OE02 trial from Great Britain, and also nowadays in Japan, they published a trial in 2012 comparing the old adjuvant regimen with a neoadjuvant regimen for squamous cell esophageal cancer. So this is mainstream, we know this very well. So on an aggregated group level, according to the trials, the data from all the trials, all patients need more treatment than surgery alone. So maybe I could conclude my talk here, and I don't need to say anything more. Thank you very much. But does one size fit all? It might happen, but it's not very common. Normally, you need to adapt treatments. And this is the case for gastroesophageal cancer too. So on what grounds should we select or avoid patients for particular multimodality therapies? Well, the first thing that comes to mind to a surgeon is that we want to avoid adverse events or complications or post-operative mortality. We all know that neoadjuvant therapy can be very demanding to the patients. And some patients, we know that too, don't make it to surgery. They don't get a chance for curative therapy because they fail after tough neoadjuvant therapy. And we have a feeling, at least, that we have more complications and more severe complications and more deaths after neoadjuvant therapy. And especially, we think that this might apply to frail patients, old patients, and patients with a lot of comorbidity. The other basis for selection or avoidance of multimodality therapy is, of course, to optimize the treatment efficacy. And this applies more to the molecular classifications we heard about earlier today and how we should optimize treatment for each subtype of cancer. I will say very little about this, but a little bit. So how does neoadjuvant therapy affect the risk of post-operative morbidity and mortality? We think we know a lot about this, but maybe we don't. This is a meta-analysis that we did from our group a few years ago. We realized that all the meta-analyses were focused only on long-term outcomes, on survival from these trials. So we compiled all the trials and we looked at the surgical outcomes, complications, individual complications, and post-operative mortality. And this is the first plot. It addresses neoadjuvant chemotherapy versus surgery alone. And this is the first plot for any complication. And as you can see, there's no effect at all from these trials on the risk of post-operative complications from chemotherapy versus surgery alone, which is very encouraging, I think. Again, chemotherapy alone versus surgery alone, or chemotherapy plus surgery versus surgery alone, and now looking at post-operative mortality. And also here, no effect. It's a very, very clear hazard ratio of 0.99. So chemotherapy, at least in these trials with a selection of patients, doesn't seem to affect complications or mortality, which is very encouraging. So what about preoperative chemoradiotherapy versus surgery alone? Well, looking at the incidence of complications, we don't see anything here either. The hazard ratio, risk ratio is 1.07, and no significant impact on the incidence of complications. Now, if we move over to mortality, we actually see a little different picture, because we see a risk ratio of 1.37. So there's perhaps a trend towards increased mortality without any increase in the incidence of complications, and it seems to be driven by the subgroup of squamous cell patients. And if we look closely at the squamous patients, there is in fact a doubled risk in these trials of dying after chemoradiotherapy compared to surgery alone. And how could this be? Why could there be a difference between squamous cell carcinoma and adenocarcinoma? I don't know, but I think one of the reasons might be that squamous cancers are more often proximal. They're more often in the mid and upper esophagus, and the radiation field might have a high risk of being on the covering the heart and lungs. So this might be one reason. Another reason might be that they are different groups of patients in terms of risk factors. Our adenocarcinoma patients are obese, but they don't smoke so much, they don't drink so much. Our squamous patients are more heavy smokers, they have more cardiovascular morbidity, more COPD, etc., and that might also influence. They have more frailty. That's my hypothesis. So the conclusions we made from this meta-analysis is that chemotherapy before surgery does not seem to have any effect, at least based on trials. While chemoradiotherapy didn't increase the incidence of complications, but there was a trend, at least among squamous cell patients, towards higher mortality. And how could that be? No increased incidence, but more mortality still. Well, perhaps the addition of radiotherapy makes the complications more severe. We have seen some of that in irradiated gastric conduits, more severe necrosis and so on, but I think that's a very small part. Another alternative explanation could be that the combination of chemotherapy and radiotherapy decreases the patient's ability to cope with the complications. But we don't know this, but we'll try to look a little bit more closely into this in a couple of papers that were published after the meta-analysis. This is a paper from Christophe Mariette's group. It's a randomized trial focusing on stage 1 and stage 2, that is quite early esophageal cancers, comparing surgery alone, which is the old standard, to neoadjuvant chemoradiotherapy plus surgery. And they included mostly squamous patients, but there were some adenocarcinoma patients. They used a platinum-5-FU-based chemo regimen with the addition of 45 gray of irradiation, almost 200 patients, and they saw no difference in overall survival. But there was a 3- to 4-fold higher mortality in the chemoradiotherapy arm. This is a very recent paper from China. It's a randomized trial published in the Diseases of the Esophagus, comparing chemotherapy, platinum-5-FU-based chemotherapy, to chemoradiotherapy with the same chemotherapy regimen, but with the addition of 40 gray, quite similar to our own NEAR-ESC trial. They randomized 267 patients. We don't have any long-term data yet. They published here the short-term data. But it showed that the patients that had the addition of radiotherapy had more pneumonia, 3 times as many high incidence, and they had a higher level of pro-BNP in their serum, a proxy for cardiac affection. So the study indicates that the addition of radiotherapy may cause more affection of lungs and heart compared to the chemotherapy alone, which is in line with some of the previous findings. Then we have our Scandinavian NEAR-ESC trial, where we compared neoadjuvant chemotherapy versus chemoradiotherapy. We included esophageal and junctional type 1 and 2 cancers, totally 181 patients, most of them adenos. And we used 3 cycles of platinum-5-FU versus the same chemotherapy, but with the addition of 40 gray of irradiation from the second cycle and on. And regarding overall survival, quite expectedly, we didn't see any difference. But looking at complications, we have some more interesting findings. Again, the incidence of complications didn't differ. There's a trend, but it's not significant. So no difference in the incidence. 90-day mortality was 6% in the chemoradiation arm versus 3% in the chemo arm. That is not significant. It's too few events, but it's still a trend in line with many previous findings. But looking at the severity of complications, using all the different ways of measuring it, we saw more severe complications in the arm with the addition of radiotherapy. In addition, when we looked at deaths during the first year after a randomization, that is after the immediate postoperative phase, the patients have left the hospital, we saw a significant difference in deaths in the patients who had complications in the chemoradiotherapy arm, which we didn't see in the chemo alone arm. So no difference in the incidence of complications between chemo and chemoradiotherapy here in this study, but significantly more severe complications after chemoradiotherapy and more delayed deaths in the chemoradiotherapy arm. However, can we say that randomized controlled trials tell us the whole truth? It's a fact that we select patients for randomized trials, and can we really generalize the findings from trials to the whole patient population that we meet at the clinic later? We performed a cohort study in the Swedish National Registry, which is very complete. We included stage 2 and 3 esophageal and junctional type 1 and 2 cancers, more than 1,000 esophagectomies, about 500 had surgery alone, 300 had chemoradiotherapy, and more than 200 had chemotherapy. And looking at the 90-day mortality odds ratio, and this is an adjusted model, we didn't see any significant effect of chemotherapy versus surgery alone. But we saw more than twofold significantly increased risk of dying within 90 days in the chemoradiotherapy arm. Looking at overall survival in the whole cohort, the whole population-based cohort, more or less all patients operated for esophageal and cardiac cancer with an esophagectomy in Sweden during this time period, we saw very surprisingly in the adjusted Cox regression model that there seemed to be no benefit in the whole group for adenocarcinomas, neither for chemotherapy nor for chemoradiotherapy, and this was very surprising. While for squamous cell carcinoma, the hazard ratio was 0.39 for chemotherapy alone, which is also a little bit surprising to me. And there was a trend for chemoradiotherapy, but not significant, looking at this whole cohort. So this is a little bit strange. Then we selected the fittest stratum of patients, the patients with ASA1, that is scored to have no comorbidity, and Karnofsky performance score of 100, totally highest level of performance status. Figures changed. Now for adenocarcinoma, the hazard ratio went from almost 1 to 0.47. So this indicates a very significant effect in these patients. It was still not fully significant. It was borderline significant. And still for chemoradiotherapy, the hazard ratio, which was above 1 before, was 0.78 and not significant at all. While for squamous cell carcinoma, we now have very low hazard ratios, 0.09 and 0.15, indicating immensely good effects on overall survival for squamous patients. So the main conclusions from this cohort study, population-based on all patients, is that we have probably overtreated frail patients in Sweden based on results from randomized trials. And this is especially apparent for adenocarcinoma patients where the risk-benefit margin seems to be smaller. So, leaving complications and surgical problems and so on, and going a little bit into the area which we've discussed the whole morning, do all tumors respond equally well to all treatment types? And I will be very brief here. First of all, I would like to mention again that there seems to be a big difference, a clear difference between adeno and squamous cell carcinoma, and that squamous cell carcinoma seems to be more responsive not only to chemoradiotherapy, but maybe also to chemotherapy. And recent data are very intriguing in showing the different subtypes of adenocarcinoma, and it will, in a few years, open up for more targeted treatments, of course. And this picture has been shown by every speaker so far today, so I will be very brief. It's interesting that the HER2 amplifications seem more or less entirely to be in the chromosomally unstable group. We have probably a very good opportunity of treating the MSI group with immunotherapy, with checkpoint inhibitors. And moreover, regarding MSI, the data from Lizzie Smith and the Marston group, the MAGIC trial post-hoc analysis showed that the MSI group did not respond at all to chemotherapy. And regarding the survival, there was a clear difference. So the patients that had the perioperative chemotherapy fared worse than the patients who had surgery alone. So the delay in surgery and perhaps also the increased morbidity of postoperative chemotherapy was not good for these patients because the therapy didn't have any effect, probably. And there are similar findings, as you know, from the classic trial, not published yet as far as I know, but will probably be published very soon. So to conclude, multimodality therapy is the curative standard of care for gastroesophageal cancers. That's true, but one size does not fit all patients. And we have a problem from these data with chemoradiotherapy increasing the severity of complications, and that might influence mortality as seen in several studies. And this is probably especially applicable to the old and comorbid patients. While encouragingly, chemotherapy does not seem to affect the surgical morbidity and mortality, which is very good. And the clear benefit that we've seen in trials of neoadjuvant therapy is difficult to translate into the same benefit when we look at a population level. And I think it's probably due to lack of selection of patients. We are treating the old and very sick patients, and we're just happy when they survive all the treatments, but it's probably not good for their cancer. And of course, the new molecular era will open up for a lot of new, more tailored therapy in the future. Thank you.
Congratulations, thank you. As during the previous session, we will